All right. Good morning, everyone. Welcome back to the University of Toronto Friday morning Grand Rounds. And it gives me great pleasure this morning to introduce Dr. David Rootman, who's a professor of ophthalmology at the Department of Ophthalmology and Vision Sciences at the University of Toronto and a chief of the cornea service at our university. He's been working out of the Toronto Western Hospital, where he is a director of the very esteemed Cornea Fellowship, along with one of our other attendees here, Dr. Alan Slomovic. Their fellowship draws both research and clinical fellows from all over the world, and it is a real feather in the hat of our department, drawing such talented individuals and increasing the scope of training all across the world. It really is a privilege for us to have such talented individuals so close to home in our department. And this morning, Dr. Rootman will be presenting to us on keratoconus, along with a couple of our superstar PGY2 residents. We've got Arshia and Joseph. So, gentlemen, thank you for the round this morning, and the floor is yours.
Thank you so much, Dr. Rai. We would like to welcome everyone to our Grand Rounds presentation titled Bend It Like Keratoconus. I'm Arshia, one of the PGY2s, and I'm presenting alongside Joseph, one of the other PGY2s, and we'd like to especially thank Dr. Rootman for allowing us to be a part of this Grand Rounds. So, to begin, keratoconus was first described by a German professor named Burchard Moschot in 1748, all the way back then. It is the most common corneal ectasia and involves progressive thinning and steepening of the paracentral cornea. The disease affects about 1 in 700 individuals, but the exact prevalence varies widely among different racial groups. It is said to be multifactorial in nature, with 8% of cases having direct genetic links, but most cases, 92% of them being environmentally related. Now, going over some of the known risk factors associated with keratoconus, the biggest one that we always ask patients about is eye rubbing, especially when associated with eczema, allergic reactions, vernal keratoconjunctivitis, or any of these conditions that predispose patients to constantly rub their eyes. When it comes to sleep apnea, this is interestingly associated with keratoconus as well. There are different theories as to why sleep apnea is associated with keratoconus, but one of them is the increased eye rubbing that ends up occurring as a result of chronic irritation and poor sleep quality and wearing masks. Some connective tissue disorders such as Marfan's and Ehlers-Danlos syndrome are also associated with keratoconus as a result of some structural weakness that happens in collagen and the extracellular matrix components that are important for corneal integrity. Floppy eyelid syndrome is also possibly related because of nocturnal mechanical trauma. The link between retinitis pigmentosa and keratoconus is documented, but this one's a little bit less well understood. And the prevalence of keratoconus in Down syndrome is quite high, ranging from 5 to 15% in some studies. And then finally, hormonal changes in pregnancy and with estrogen therapy are linked to the disease, as well as hypothyroidism. Now, with regards to rubbing, this is just a dynamic MRI video showing just how much the cornea and the overall globe contorts with eye rubbing, and how doing this thousands of times over and over again throughout a lifetime, especially in your early adulthood, eventually takes a toll on your eyes. I just thought it was an interesting video to show.
That is striking. Wow.
Yeah. Now, taking a look at worldwide keratoconus prevalence, we can see that there are certain hot zones that tend to be centered around the Middle East and South Asia. This doesn't mean that keratoconus can't happen in other low-risk populations, but it's important to have a higher risk and a higher suspicion for patients from these at-risk populations. With regards to the pathophys of keratoconus, it involves fragmentation of Bowman's layer, thinning of the stroma, and overlying epithelium, folds or breaks in Descemet's membrane, and variable amounts of diffuse corneal scarring. Keratoconus, we know, typically presents in adolescence and progresses until early adulthood when it slows down. One interesting theory that we were reading about that shows why it stops after early adulthood is just the natural UV light exposure that you end up getting from being outside, as well as aging of the cornea results in natural cross-linking by itself. And we'll get later on onto why cross-linking is a possible important treatment for keratoconus. Here at the bottom, we can see some histology slides. On the left, we can see the normal histology of the cornea with its 5 layers. And then here on the right, we can end up seeing a case of keratoconus where we can see a clear break in Bowman's layer with associated stromal thinning. Keratoconus normally presents with monocular blurred vision. Some patients describe ghosting, diplopia, sometimes even triplopia, increased glare and flare from lights, and a refractive error that keeps changing or that the patient's optometrist can't fully correct. At the slit lamp, there are a lot of signs that you can look out for. None of them have 100% specificity or sensitivity, but one thing that you might notice is vote striae on the left, an oil droplet reflex that you can see here in the image on the right as well, that is most pronounced on retroillumination. Another test, which is not commonly performed, but we read about in textbooks, the residual light reflex, where light shine from the temporal side creates this conical light reflex on the nasal side. You may also notice a fleshing of iron that's deposited in the deep epithelium. And one of the easiest ways to notice this is by shining a blue light filter. But this finding is only present in about 50% of patients. So this brings us to our first poll question. Which one of these images is keratoconus? Is it 1, 2, 3, or 4?
I'll give that a couple of seconds to run there, Arshia.
Okay.
There you go.
They don't let us do it.
Right. So most people got the answer correct. So 1 is a completely normal cornea. No one chose that. 2 is keratoconus. 3 is pellucid marginal degeneration, and 4 is keratoglobus. One good way that we can remember that pellucid marginal degeneration is the saying belly above the belt, where the area of protrusion is above the area of maximal thinning. And the last image on 4, the image 4 here, is keratoglobus, which tends to be present since birth and demonstrates diffuse thinning and protrusion. Now, when it comes to tomography, there's a lot of numbers that we can end up seeing on these images, and sometimes it's hard to analyze these images, but some guidelines as to what to look for to be able to detect keratoconus include these following characteristics, and these are from the AO manual as well. So seeing overall steepening of more than 47.2 diopters is one indicator. Seeing inferior steepening or superior flattening, an increase in the inferior to superior ratio of more than 1.2, skewing of the radial axes of more than 21 degrees, some isolated islands of elevation, abnormal thinning, less than 500 microns, and especially so if it's less than 470 microns, either posterior elevation of more than 12 or anterior elevation of more than 17, an inferior superior difference of more than 30 microns of the 5mm ring, or a difference of 30 microns, more than 30 microns between the two eyes in the thinnest area, or inferior decentration of the thinnest part of the cornea. These are all signs that point us towards keratoconus. So this brings us to case number 1. So we have a 24-year-old man from Colombia who is otherwise healthy. He's a known eye rubber, and he was referred to our cornea clinic by his optometrist after complaints of blurry vision and sudden changes in his prescription. His best corrected visual acuity was still good at 20/20. He had normal eye pressures, and you can end up seeing his refraction down below as well. His occupation is that he works in sales. Overall, he had a grossly normal anterior segment exam. However, pachymetry readings demonstrated thin corneas bilaterally, with readings of 458 microns on the right and 463 microns on the left. And down below here, you can end up seeing his K readings as well. So corneal topography in this case reveals an irregular astigmatism. And right away, we can see that there is inferior steepening bilaterally. And taking a look at the placido rings on the right, we can see that they're not perfectly circular. There's slight changes. So using the rules that we previously discussed here in the right eye's tomogram, there are a number of indices that are abnormal. First, we can see that the anterior elevation is more than 17. We can see that the posterior elevation is more than 12. It's 38 in this case. The thinnest area is less than 470 microns. The Kmax is more than 47. And the thinnest location here is displaced inferiorly with a y coordinate between -0.5, -0.1, and this matches with the Kmax location. So there are a number of abnormal indices here that point us in the direction of keratoconus. And we can see that there are similar findings here in the left eye as well. So this brings us to poll number 2. For this patient, what treatment option would you pursue at this time? Choice 1 is crosslinking. Choice 2 is DALK. Choice 3 is PKP. Choice 4 is intracorneal ring segment implantation. And choice 5 is close observation for now.
I'll give that a couple more seconds there to run. But it looks like you've got a bit of a split.
Okay, interesting. Yeah, split between cross-linking and close observation. Nobody wanted to do a DALK on a 20/20 vision. So we decided to do cross-linking for this patient. So here in this video, you can see an example of a cross-linking video. You can see that in this case, the epithelium is being debrided. Then riboflavin is applied to the cornea, and it's this yellow mixture right here. And there's various different protocols at different centers. At TLC, the protocol involves placing riboflavin drops every 2 minutes for 10 minutes. Once the cornea has adequate penetration of the riboflavin into the stroma, there's this cross-linking machine that's placed over the patient's eye for 5 minutes. And the patient looks up into the machine to see a series of UV lights. And then after the procedure, because the epithelium was debrided, we place the BCL in the eye for comfort. And then post-op, we follow this patient. We start them on topical steroids, oftentimes Maxidex QID, as well as artificial tears and antibiotic eye drops, gadifloxacin, for example, until the bandage contact lens is removed. Now, collagen cross-linking is relatively contraindicated in certain cases. So,
Can you just stop for a moment? That excellent presentation. Why do you think that 40% of the people said to observe and 60% said go ahead with cross-linking? I mean, what's the pros and cons of both options?
right, I guess with we don't know right now when the patient was referred to us where they are in the course of their disease, if they're in their stage of the disease where they're rapidly progressing, or if they're in a part of their disease that's relatively stable. They still have 20/20 vision as well. So maybe some people would be hesitant to do a procedure on a patient who's still 20/20. But we can see why cross-linking would still be beneficial in this case. They have features on the tomogram of keratoconus, and it may be worthwhile to catch this disease early on while they are still 20/20, and while we can still slow this disease down before they reach a point where they develop some of the complications associated with keratoconus and require other more invasive surgical procedures.
In other words, we can't turn back the clock. We can only stop the keratoconus where it is. While some people do get some improvement due to some flattening of the cone, you can't promise that to the patients. So in this gentleman, he's 24, he's relatively young. And if you asked him, he would probably tell you his vision was better 2 years ago. So what I'm trying to get at is that some people like to wait for progression, and that's associated with all of the studies, the early studies that were done. They didn't want to treat someone unless they had actually formal evidence of progression. But I think knowing how safe and effective the treatment is, most people would say that if there's what I would call historical progression or evidence of worsening of the vision, that you don't wait until you've got topographic or tomographic information that shows progression, because you can't turn back the clock if you've waited a year to see if they've progressed and then they do progress. So I think his age is a risk factor, his rubbing. There's no information about whether he's got sleep apnea, but I think often we diagnose the patients as they're walking down the hall towards the clinic at Kensington, and there seems to be a preponderance of males that get to us, and many of them are heavy set, either heavy set in the shoulders or they're just somewhat overweight. And it's really important to ask them about the sleep apnea. I can't believe for 20 years it wasn't obvious to me, but for the last 15 years or so, it seems that first of all, there's an epidemic of sleep apnea, And it is a major risk factor for the disease presenting as well as getting worse.
Thank you, Dr. Ruman. With regards to cross-linking, there are certain contraindications, some relative and some absolute contraindications, but some relative contraindications include patients that have a corneal thickness less than 400 microns. The theoretical reason behind this is that a thin cornea allows UV light to potentially end up reaching the corneal endothelium, and this UV light can end up causing endothelial cell loss. And you can see here on the picture on the right an example of endothelial cell loss in a patient that had cross-linking performed. There are, however, a number of protocols that allow for the treatment of corneas even as thin as 300 microns, and we'll get to this in the next slide. Another relative contraindication is prior herpetic infection, just because of the theoretical risk of reactivation with UV light. Severe corneal scarring or pacification would probably lead you towards doing a keratoplasty rather than actual cross-linking itself. And then finally, a history of poor epithelial wound healing, severe dry eyes, and autoimmune disorders are just general contraindications to a lot of cornea procedures, not just cross-linking. Now, the standard protocol is the Dresden protocol that involves applying riboflavin every 2 to 5 minutes to the eye for 30 minutes, followed by UV exposure for 30 minutes. However, there are a lot of variations to the procedure that can be employed. At TLC, the accelerated protocol is used, which avoids the need to have the patient treated for over an hour. The reason the accelerated protocol works is that it uses stronger intensity of UV light. And also, since we mentioned that greater corneal thickness protects against UV damage to the endothelium, in thinner corneas between 320 and 400 microns, you can still do corneal cross-linking, but you can end up using a hypoosmolar riboflavin, which allows the cornea to thicken up to a minimum of 400 microns, which then allows you to safely proceed with the procedure. So for this patient, post-op, 3 months afterwards, he had an uncorrected vision of 20/40 and a BCVA of 20/30. And then 2 years after the procedure, he had no progression of his ectasia so far, and so far, at least, he's quite satisfied with his outcome. Now we're going to move on to case 2. I'm going to hand it over to Joseph.
Hello, everyone. So now going forward with case 2, this is a 23-year-old Western European male diagnosed with keratoconus about 4 years ago, with poor compliance with rigid gas-permeable contact lens, noticing worsening of his vision for the last few months. He claims that he does not rub his eyes, no snoring, no known sleep apnea, otherwise healthy, and no medications, no past ocular history. He works as a construction worker. The uncorrected visual acuity is 20/50 in the right eye, 20/50 in the left, corrected to 20/50 bilaterally with glasses. And you can see here the prescription for this patient where there is significant astigmatism in both eyes, slightly worse on the right. The anterior segment exam showed normal lids and lashes, white conjunctiva. Cornea had a central area of thinning with both striae, and anterior chamber is deep and quiet. He's phakic in both eyes. Pachymetry readings showed a thickness of 419 in the right and 442 in the left, with a Kmax of 63.2 in the right and 56.8 in the left. So again, it's a bit worse on the right compared to the left. And here you can see the corneal topographies revealing an irregular astigmatism with inferior steepening that is present bilaterally. And you can see here in the Placido-based images, the rings are irregular and asymmetrical, more inferiorly compared to superior in both eyes. And it's also all these indices showing worsening disease in the right eye compared to the left eye. And now onto the pentacam images of the right eye. We can see here that there is an area of inferior steepening. There is anterior elevation as well as posterior elevation. The anterior elevation is 51 and the posterior elevation is plus 90. And here to remind you that, as Arshia alluded before, anything above 12 is actually abnormal. And the thickness map in the bottom right is showing thinning of the cornea with central corneal thickness of 419 at the thinnest point. The left eye is showing similar finding with similar patterns with a Kmax of 54.1 and inferior steepening. Same thing, anterior elevation and posterior elevation maps. And the thinnest part of the cornea is 454. So here I will introduce the treatment option that we decided to go forward with for this patient with the intrastromal corneal ring segments. So these ring segments were initially approved by FDA. They are commercially known as Intacs, and they are circular arcs made from PMMA. They are implanted in the posterior mid-peripheral stroma to more commonly treat mild to moderate keratoconus. And they are not curative, but they kind of act as a scaffold to decrease the steepening or flatten the cornea a little bit and prevent the disease progression. Given that the right eye had worse vision, we decided to proceed with both an intrastromal ring segments and corneal cross-linking, as Arshia showed in the previous case. So although it's a great option to do these ring segments, they also come with a bit of contraindications. So for example, on the FDA label, it's required that the central corneal thickness is at least 450 micron at the incision site. And it's not recommended if the main K is above 58, if there is central corneal scarring or active collagen vascular or autoimmune conditions. And this is a video of how it's done. First, the cornea is marked, and then involve creating a lamellar tunnel at approximately 60 to 70% of stromal depth. These tunnel can either be done by a diamond knife or femtolaser. After the tunnel is made, specialized forceps are used to insert the first segment of the ring segments, and then it's rotated. So you can see here, this is the tunnel is created. The rings are introduced into the cornea. So this is the first ring that is then rotated into position. And then after that, the second ring is also inserted into its position and rotated appropriately. So after it's put in position, it can be like put in place with sutures to ensure that it stays in the proper placement. And although it's a great option that works fairly well in mild to moderate keratoconus, there are also potential side effects that could happen with these ring segments. So on the picture on the left here, one complication is the extrusion of these ring segments out of the cornea, and you can see it's shown here in the colored image and on fluorescein. The other complication that could happen is thinning on the stroma overlying these ring segments, as you can see denoted by the arrow in the middle picture, and that's why there is a minimum corneal thickness for these ring segments to be introduced. Other complications as well include new vascularization around the ring segments and also deposit formation. So post-operatively, this patient best corrected visual acuity has improved to 20/20 -1 in the right eye and 20/30 in the left eye. And as you can see here from the prescription is that the astigmatism has improved significantly after introducing the ring segments and cross-linking. Here are the tomography maps of both pre-operatively and post-operatively. And you can see here, especially on like the steepening inferiorly, there is a marked improvement compared to pre-op. Same thing with the left eye. So that brings me to the third poll question, which is, which of the following is keratoconus?
All right, we'll end that there.
So there were quite a split here, more so that the second image is keratoconus, and actually all of them are. And I will go to discuss each case.
We'll just stop for a moment here. Is that, you know, so far what we're looking at are treatments for mild to moderate keratoconus. And you have to make a decision of how you think the patient's going to do before you go ahead with the treatment. And one thing that I find very useful, and I noted in your presentation, is that his corrected vision with the 4-opter was 20/40 in both eyes. And what that tells us is that the optics of the cornea are not too messed up at that point. If you can use your manifest refraction as a guide, and there have been studies that have shown, some people have shown that people that see better than 20/80 may benefit from these maneuvers. But I think that I like to see it. I like to see the manifest refraction better. So if you're 20/40, they're likely to pick up maybe 1 or 2 lines. I was surprised that he got down to 20/20. The other thing is that when the rings first started, they were actually prescribed for myopia. And many of the myopia patients didn't like them too much because they got glare from the edge of the intact. But things have evolved, and for keratoconus, there's a specific ring that's designed for keratoconus. It has more of an oval profile to it. The other thing is that most of these patients, if you look at their topography, if you cover up the lower half of the topography, the upper half is either normal or it's flat. It's blue on the topography. And if you put an intact in there, even though it's a thinner intact, it's going to increase the flattening of the superior cornea. And so as things have evolved, it's actually become much easier. We just use the thickest segment with the smallest radius of curvature, which is the one that's specifically designed for keratoconus, and just put it in below where the cornea is reddest. So it makes it really easy. You just you don't have to think too much about it. You just look where the maximal point of the cone is, and you rotate the inferior segment into that region, because in all of these cases, you want to get maximal effect. And you could see you decrease the cylinder by more than 2 diopters, which is really significant. So you know, if you put a superior one, you may have to go back and take it out. And so I haven't put in 2 segments in many years now. And it is a very effective treatment with very few complications, although some people claim the opposite. But you know, we put in many over the years, and very few have had to be removed.
That's very interesting. Thank you, Dr. Rootman. So For the first case here, the panel above is the topography, and it shows actually a mild keratoconus. And the tomography below, you can see here the anterior and posterior elevations, as well as the corneal thinning with a Kmax of 60.3. And on the right here, you can see that the Bellin module is also showing the keratoconus. And that is very helpful because the Bellin module actually, instead of normalizing the patient tomography to an average or a normal cornea, it actually looks at a 4 millimeter thinnest part of the patient's own cornea excluded from analyses, and kind of make a form where it will show what would the patients themselves cornea look like without keratoconus, and it's showing the difference. And you can see here the difference at the bottom panel is between the front and the back elevation. The second image, which a lot of people alluded to as a keratoconus, and it's actually a keratoconus, although it shows here a crab claw pattern, but however, the thinning is central and not peripheral, which actually differentiates it from pellucid marginal degeneration.
Yeah.
So it's important to note here that not everything, keratoconus does not essentially present as a bow tie pattern. So it can present as many other patterns. Sorry, Dr.
I think you need, it's really this, I'm glad you showed this slide. It's important to emphasize because it's not a pathognomonic sign for pellucid marginal degeneration, the crab claw or the kissing birds, whatever you want to call it. It's more often keratoconus. And when you see the crab claw, take a look at the axis of it. If it's towards 90, in other words, it's heavily weighted towards against the rule of astigmatism, it's almost always vertical with pellucid marginal degeneration. If it's off to the side, particularly if it's tilted towards the outside, then that's more likely what I would call a pellucid-like keratoconus. It's not really pellucid at all. It's just plain old keratoconus. So just because it's crept into your mind that crab claw equals pellucid marginal degeneration, that's not the case. It's not pathognomonic.
Yeah, thank you, Dr. Wing. And the third case here is also another example of severe keratoconus. So you can see here there is a high irregular astigmatism together with anterior posterior elevation and central thinning of the cornea, with also NDCs positive in the Bellin-Ambrosio module. So just these are all to show that keratoconus tomography can present with different shapes, and it's important to pay attention to the fine details, like also what Dr. Rootman mentioned, when you see a case of keratoconus or other corneal ectasias. So going forward with case number 3, this is a 69-year-old female with a past medical history of hypertension, high cholesterol. She's taken medications for these conditions, and she has a past ocular history of keratoconus since age 27, which managed with contact lens. But she suffered from deteriorated vision. She also was not able to tolerate her contact lenses anymore. She's retired and she rubs her eye quite often. Her uncorrected visual acuity is counting fingers in both eyes, and her best corrected visual acuity is 2400 in the right and 2100 in the left. And here is a topography image showing how contact lenses can affect the corneal curvature. And what I want to show you here is that you can see the Placido images at the bottom. You can see how without the contact lens, the rings are irregular, especially inferiorly. And once the patient put back the contact lens, you can see how the rings become fairly more regular compared to without the contact lens. So the anterior segment exam in the right eye showed normal lids and lashes with white conjunctiva. She had high drops with Descemet's membrane detachment and a small tear at 3 o'clock. The anterior chamber is deep and quiet. She's phakic in both eyes. In the left eye, she had Vaught's striae and a faint fleshering. Her care readings show in the right a minimum of 51.84 with a maximum K of 64.04. And in the left eye, she has a minimum of 50.83 with a maximum of 55.79. And here are her topographies. So in the right eye, her topography shows inferior steepening with maximum K of 64.04. And the placido rings here, you can see more inferiorly, they are very asymmetric. And the left eye topography, you can see inferior steepening as well with a K of 55.79. So that's a bit better compared to her right eye. And the placido rings irregularity is obvious at the bottom right. So the first step in management was managing her high drops. And that was done with an injection of a gas bubble with C3F8. 1 week after the bubble injection, or actually 2 days after the bubble injection first, her visual acuity stays at 2400, cornea is clear, the Descemet's reattached, the anterior chamber remained deep and quiet. And then 1 week after, we proceeded with surgery. And first, before I show you what we managed with this case, I want to show you what advanced keratoconus has. And typically, patients with late keratoconus would start to have scarring. And this scarring can varies from reticular scars that occurs from breaks in the Bowman's, or a nummular scarring that happen at the corneal apex from contact lens wear. Other scarring include the deep stromal scarring from previous corneal high drops. And you can see here in the image, the scarring at the Bowman's layer. So the other thing is when to decide to move ahead with keratoplasty. So there are many indications for keratoplasty. This include poor vision, even with good contact lens fitting due to scarring oftentimes. Contact lens intolerance, despite the good vision achieved with the lens, or unstable contact lens fitting, even if the patient is having good vision and is able to tolerate the contact lens well. Also, progressive thinning towards the corneal periphery, approaching the limbus is another indication for keratoplasty, because if it approached the limbus, it will require a very large graft, and that is associated with increased risk of rejection. The other indication is corneal high drops that fail to clear after several months. So for DALK, which is the treatment modality we decided to go ahead for this patient, it's a fairly good treatment, but it also has some contraindications. So one of them is unhealthy endothelium or Descemet's membrane. 2 is scarring involving the Descemet's membrane or corneal endothelium. And the third one is actually a relative contraindication, so it's not absolute, which is breaks in the Descemet's membrane. And I will show you in this case where one eye had high drops and the other didn't, and we moved forward with DALK in both eyes. So this is a video of a DALK from another patient. And you can see here marking of the cornea. A suction terrifying is used to make a 90% dips incision. The anterior stroma is then removed with a crescent blade. And then an air bubble injector cannula is used to create a big bubble that displaces the Descemet's membrane posteriorly. So this is just stripping here of the stroma and removing of the cornea. And you can see that there is glistening from the air bubble. So now the big bubble is then entered using a sharp blade. And then the Descemet's membrane is determined typically by its glistening appearance. Then the residual stroma is divided into four quadrants. And then each quadrant of the residual stroma is then removed. And here is what is left is the decimase. Then the preparation of the donor tissue, where a trypan blue is being used to identify the endothelium and decimase. And after then, the endothelium and decimase are stripped. And the donor tissue is excised using an 8.5 terafine. This is to match the same size of the host bed. And then the donor tissue is sutured in place using a 10-0 nylon interrupted and continuous sutures. So post-operatively, at 1 month, the patient best corrected visual acuity has improved to 2100 in the right, 2300 in the left, and then it continues to improve at 3 months to 2070 and 2080. And as of last week, 10 years after the DALK procedure, she has a vision of 2050 in both eyes. So even she had high drops in the right, still the DALK was able to achieve similar results between the right and left eyes.
Yeah, I think that there's a couple of points here. One is, as you mentioned, even if there is some scarring and even if there has been a perforation, it may be worthwhile to try a DALK. You may not get a big bubble, but you can probably do a manual dissection, because if you just go down, we used to think that when you do a DALK, you get down to decimase membrane. Well, it isn't true, really. It's been defined in the last 10 years by Professor Dua in Nottingham that there's actually another layer of compact stroma that's actually taken its name, called Dua's layer. So if you do get a big bubble, it's the best separation is between the posterior stroma and Dua's layer. And that actually gives you about 20 or 30 microns of protection. And that makes the dissection so much easier. And also, if you do a manual, you're most likely going to be separating between Dua's layer and posterior stroma. And if there is a little posterior scar, it doesn't bother me too much. I think the risk of reduction in rejection risk is so much better that it's worthwhile. And often these little scars are off center because their cones have been decentered. And I'd much rather have a 30 or even a 50-year-old patient living with their own endothelium, an intact posterior part of their cornea, so that trauma is much less of an issue, than have them lifelong risk of having rejection. Especially, we're doing these grafts a little bit larger these days. Some of us, like to do large PKPs. I don't, because rejection is a serious complication, and only 50% of the corneas recover from a PKP rejection, whereas a DALK rejection, they all recover, and it's much less frequent as well.
Thank you.
One other point I wanted to make, and that is that would you cross-link this patient? Let's say she was 25 and had severe keratoconus, and you planned on doing a DALK or a PKP.
I'm not sure, but I don't think it will be a good option for her based on like the severity of the disease. I don't know. I don't think it will delay the progression, especially if there is severe corneal thinning associated with it.
Well, I would suggest that it may be worthwhile to do the cross-linking even still, because we don't excise the entire cornea. We leave the peripheral, say 2 millimeters of cornea all the way around. And if you don't cross-link them, then it's the equivalent of building a house on a soft foundation. And we see in many of our patients that we operated on before cross-linking, they come back with increasing astigmatism, thinning on the posterior side of their graft-host junction, and continuing progression of their keratoconus. So I don't have data to prove it, but in general now, I try and encourage cross-linking before. And I may do it three months before doing a DALK or a PKP, in the hopes that whoever takes over these patients 20 years from now is not going to have to deal with increasing astigmatism and thinning of the graft, or thinning of the graft-host margin, or the cornea peripheral to it.
Well, that's very interesting. Thank you, Dr. Rootman. So that's a slit lamp video of the patient as of last week. Yeah. So you can see here that the corneas 10 years after the DALK are still clear. She had no complications, no signs of rejection. So that's her right eye.
Dr. Ulate has made a comment as well. We don't cross-link the peripheral cornea. It's quite correct, but you know, it's not a laser light; it's a regular light, and the riboflavin diffuses into the peripheral cornea as well. So you may not be getting as good cross-linking as you do in the center, but I do believe you get cross-linking all the way out to the limbus, and that's why it's worthwhile doing. Or at least at the graft-host margin, you're going to get more intense cross-linking.
And here are the topographies as of March 2025. And what you can see here in the right eye, the DALK graft is intact with no inferior steepening and relatively regular placido rings with a K of 47.54. And similar results are also in the left eye with a K of 48.08. So that's it for the cases. We would like to thank Dr. Rootman very much for his for allowing us to present in Grand Rounds and for his support on this presentation and cases. We would also like to thank Marcella Huertas Bello, the Cornea Fellow, for all her help on the presentation and cases as well, and More Barakat for supplying us with the videos. And thank you all for listening. We're happy to take any questions.
Just before we finish the rounds, I wanted to thank both of you for doing a superb job. It made my job extremely easy, and for Marcella and More, Marcella put a lot of effort into supervising and providing you with some really good images to illustrate the points. So kudos to all of you. You've done a fantastic job. I'm really impressed. You should save that lecture because you could give it anywhere.
Thank you so much.
I agree. Great job, Archie and Joseph, and Marcella and More and Dr. Rootman. Thank you guys. There's a couple questions for you in the chat here. Maybe for Dr. Rootman, can you do Intacs if the max K is greater than 58?
You can. In general, you wouldn't, because those patients often don't have correctable vision. In other words, their corneas are probably too far gone to have an intermediate intervention like Intacs. There are some new varieties coming out, such as what they call CTACs or CARES, where they're using actual human tissue as an intact substitute. And that's showing some changes in the topography related to it without the chance of rejection, and it's natural tissue. Well, there's a slight chance of rejection, but I don't think it's very common. My problem with it is that we've got lots of visual acuity data with Intacs, and we published several studies on this more than a decade ago. Whereas with the human corneal implants, there's lots of nice pictures, but I don't see a lot of published data on how great it is in terms of the vision. Now, maybe it's just because it's early stages and it hasn't evolved to that step yet. But if someone knows of any visual acuity data, I'd like to know. The second question is from Myrna Lichter: social history important in deciding treatment? In your marginalized patients with the monocular keratoconus, yes, I think it's important to know what kind of environment he's going to go back to. You know, if he's at risk of being traumatized, or he's going to be at risk of not following up, or he's going to get an infection in his only eye, then I think I might consider just leaving him with the limited vision that he's got. And social history is always very important, and if you include obstructive sleep apnea in that, I guess that's more personal history. But you know, you've got to take the whole gestalt. And the other thing is that for many years, I wasn't really a big fan of contact lenses. And the reason for that is that so many of my patients actually came because they were contact lens intolerant. I started to believe that contact lenses don't work very well in keratoconus, because all of my patients were coming and telling me how much they hated them and they wanted to get out of the contacts. But I think in the last 10 years, there's been a big improvement and sort of a resurgence, a trend back towards very, very large contact lenses, and even some customizable ones that they can use laser printing to make a custom lens for these patients. And since that time, I've been impressed with how comfortable many of the patients are. Some still can't deal with this. The scleral lenses are very big and they have trouble getting them in, or they're uncomfortable after a couple of hours. But a lot more patients, I think, are being successful. So I think our surgery rate has gone down. Certainly 10 years ago, I was doing quite a few DALKs, and now I maybe do one a month. And that's probably a combination of crosslinking, which has decreased the pool of people that go on to need corneal transplants. And the other one is the success with contact lenses and proliferation of optometrists that are willing to take on these difficult cases.
David, 2 points. One about the contacts. You know, having spoken to Sylvia Rodriguez, who does, we are the only center in Canada. We're the first center to have it, and the only center that government covers the cost. She says pretty much any, barring scarring, even advanced corneas with keratoconus, she's been able to fit with a PROS lens. Now, these are really big lenses. Not everybody can manipulate them, but a lot of these keratoconics are young patients with reasonable manual dexterity. So I think that also has been a important factor in treating a lot of these patients. You're right, and I think the dual impact of collagen cross-linking, which has been with us now for at least over a decade, we've actually been able to reverse the tide of patients going on towards needing DALK or penetrating keratoplasty. So that's been a really positive change in terms of advanced keratoconus. Also, you know, we will be starting the CARES. Neera is leading that charge, and she's almost completed getting all the equipment. She has the equipment. We just got to get a couple of more things on her to-do list to get this up and running. The nice thing about CARES is because we're using donor tissue that would not be not necessary for corneal transplantation. They'll be more readily available, and also the cost goes right down because you're not having to purchase these intact segments. I'm not sure where they're coming from, but I think they're coming from the United States. So the cost is high, and hopefully our own eye bank will be able to provide the human tissue for CARES.
There were a couple other questions here. The one about, do I have a cutting age where the patient presenting with KC you decide to observe for progression or indicate cross-linking directly? Well, the younger they are and the more progressed they are, the more likely I am to cross-link them. And so I think age is a very serious risk factor, because the young patients, their corneas are mushier and they tend to progress. And if we see keratoconus in one eye that requires CXL, if they're young, I would offer them to do the other eye as well, especially if they've got signs of already some mild signs of keratoconus. Or depending on the patient, I may say, you know, let's leave that eye alone for now, and if you stop rubbing, maybe it won't get worse, and we'll follow you closely. So there's no definite answer for I don't have a cutoff age, but certainly younger patients, I'm more likely to cross-link both corneas.
And just one more question here from Miriam. Is there a lower and upper age limit for treatment for
No.
cross-linking?
No, I mean, the textbooks say that keratoconus rarely progresses beyond age 40, but I think there are definitely exceptions to that rule, just like any rule. And many people have documented progression in older patients, likely those that can't stop rubbing their eyes. And you know what I always ask the patient, how do you rub your eyes? And if they go like this or like this, that's very bad. In fact, we had 3 patients from the Tourette's clinic many years ago who one of them rubbed both eyes and the other one only rubbed one eye. And of course, it's the eye that rubbed that developed keratoconus, with the other eye being totally normal. So, you know, these are things to watch out for. And it's a very prevalent disease. I think much more prevalent than we used to think. We used to say it was, I think, less than 1% of the population. But now with our better diagnostics and with so many people going for screening for laser surgery, they're getting better analysis. And we're just seeing keratoconus coming out of the walls as far as I can tell.
David, I had one patient who, talking about unilateral keratoconus, we have, you know, typically we consider it a bilateral disease. I also had one patient who rubbed one side continuously. Keratoconus on that side went all the way through to perforation, just
Wow.
on that side.
Wow. You know, these are what keep us going, all these unusual circumstances. But thanks, Alan, for your comments. They're always welcome, and you guys are terrific. Keep up the good work. Wow, I was impressed. That was the best presentation I've seen on keratoconus in a long time.
Thank you so much, Dr. Rootman.
Well, that's kudos to all of you. So thank you guys again for a wonderful presentation and a great grand rounds. And Marcella, you too, thank you for the hard work in addition to the residents. We do have Jack Crawford Day next week, so I hope to see many of you there. Enjoy the rest of your Friday. Thank you, everyone. Thank you, Dr. Rootman.
Thank you.
Yeah.